Good afternoon, everyone. Thank you for being here this afternoon for the symposium, which is entitled The Tidal Wave is Coming, Heart Failure Diagnosis, Prevention, and Treatment in Patients with Type 2 Diabetes. Just so you know how the symposium will run, each of our three speakers will give a presentation for about 15 minutes, and then we will have a full 15 minutes at the end for questions. So please hold your questions until after all of the speakers, after we've heard from all of the speakers. So our first presentation is on the etiology of heart failure with preserved ejection fraction and with a focus on the role of diabetes, to be presented by Dr. Ravi Patel from Northwestern University.
Thanks very much to the ADA and the Committee on Scientific Sessions for the opportunity to discuss the role of diabetes and mechanistically how it plays a role in heart failure with preserved ejection fraction. It comes as no surprise to many of you in the audience that diabetes and heart failure commonly coexist. In this analysis of the Get With the Guidelines Heart Failure Registry, over 40% of individuals hospitalized for heart failure had concomitant diabetes. Over the 10-year span of this study, the prevalence of diabetes appeared to increase and was more common among those individuals with heart failure with preserved ejection fraction as compared to those hospitalized for heart failure with reduced ejection fraction. In addition, diabetes confers formidable and equivalent risks across the heart failure spectrum. In this meta-analysis of several epidemiologic cohorts, the presence of diabetes conferred an over twofold increased risk of heart failure with preserved and reduced ejection fraction compared to those without diabetes. And kind of interestingly, in this meta-analysis, the effect estimate or the relative risk of either HFpEF or HFrEF as demarcated by the white diamond was essentially equivalent, 2.22, which begs the question, which patients with diabetes go on to develop heart failure with reduced ejection fraction as compared to preserved ejection fraction? Shown here is a figure of broad mechanisms that may drive heart failure in diabetes. In the setting of hyperglycemia, insulin resistance, and hyperinsulinemia, as you can see on the red diagram on the screen, incites inflammation, dyslipidemia, endothelial dysfunction, rapid progression of epicardial coronary disease and ischemic cardiomyopathy, which is a clear mechanism by which heart failure with reduced ejection fraction occurs in diabetes. On the right-hand side of the screen, you'll see several other mechanisms that result in a catch-all term of diabetic cardiomyopathy, cardiac, structural, and functional impairments in the setting of diabetes that may be due to autonomic dysfunction, RAS activation, cardiomyocyte hypertrophy, the formation of advanced glycation end products. But which of these patients with diabetes and which of these mechanisms specifically causes heart failure with preserved ejection fraction as compared to reduced ejection fraction? I hope to shed light on a few of these potential mechanisms in this talk. The first is insulin resistance. Insulin resistance appears to be specifically associated with the development of HFpEF compared to HFrEF. In this analysis of several cohorts evaluating cardiometabolic trait associations with heart failure subtypes, only HOMA-IR was specifically associated with incident heart failure with preserved ejection fraction with a null association with heart failure with reduced ejection fraction, suggesting insulin resistance may be a specific mechanism towards HFpEF. Insulin resistance may drive diabetic cardiomyopathy and HFpEF specifically through alteration in mitochondrial metabolism at the level of the cardiomyocyte. Several basic science studies have demonstrated that insulin resistance leads to essentially a metabolic shift at the level of the mitochondria away from glucose oxidation and towards fatty acid oxidation. This increase in fatty acid uptake can result in increased reactive oxygen species, inflammation, an increase in advanced glycation end products, ultimately creating mitochondrial dysfunction at the level of the cardiomyocyte, calcium handling abnormalities, and ultimately diastolic dysfunction and heart failure. The concept of altering fatty acid oxidation and switching metabolic shifts is being tested right now in HFpEF with a drug called ninirafaxat. Ninirafaxat is a partial fatty acid oxidation inhibitor which shifts the metabolism of the mitochondria away from fatty acids and towards glucose oxidation. Ninirafaxat has been studied in a phase 2A trial called Improved DICE, which enrolled individuals with HFpEF, diabetes, and obesity. It was a single-arm study of this drug over 3 months. And ninirafaxat, again, a fatty acid oxidation inhibitor, appeared to improve mitochondrial energetics by phosphocreatine to ATP ratio. In addition, improved both LV and RV systolic function by augmentation of stroke volume and cardiac output. The correlation between improved mitochondrial efficiency appeared to be highly correlated with improvements in contractile performance of the LV and RV, with some modest increases in exercise capacity. The concept of decreasing fatty acid oxidation has also been studied by one of my co-panelists, Dr. Jim Januzzi, through aldose reductase inhibition. Aldose reductase is an enzyme involved in the polyol pathway converting glucose to sorbitol, and it's felt to have impaired metabolic effects overall, leading to diabetic cardiomyopathy. Inhibition of aldose reductase with a compound AT001 decreases the amount of fatty acid oxidation. And in a RISE heart failure, 691 individuals were randomized to this aldose reductase inhibitor compared to placebo. And while the primary outcome of change in peak VO2 was no different, there was a subset of individuals who appeared to benefit who were not on SGLT2 inhibitors or GLP-1 receptor agonists, again, providing some evidence that shifting metabolism away from fatty acid oxidation and towards glucose oxidation may be a potential therapeutic target in HFpEF. Another pathway that seems to be more prominent in driving HFpEF among those with diabetes than HFrEF is the expansion and inflammation of epicardial adipose tissue. This is a patient of mine who I see in clinic. I primarily see patients with heart failure with preserved ejection fraction. She's a 67-year-old female, South Asian, type 2 diabetic. She's overweight but not morbidly obese by any means and has exertional dyspnea and HFpEF. As you can see above her RV, she has both epicardial fat, which is just adjacent to the RV. You can see it most prominently at the apex, and she has a ton of pericardial fat just outside of the pericardium. In the setting of diabetes, it is felt that both a combination of obesity and diabetes, and again, there's a high overlap, 65% of patients with diabetes have obesity, but in combination, these two syndromes can result in not only an expansion, but also a shift in inflammation of this adipose tissue, resulting in microvascular dysfunction and ultimately impaired ventricular distensibility, leading to HFpEF. The concept of pericardial adiposity as a potential mechanism that drives HFpEF has been essentially corroborated or studied in the SUMMIT trial of tirzepatide in obese HFpEF. In SUMMIT, patients were randomized to tirzepatide as compared to placebo, in which a composite clinical endpoint was met for superiority for tirzepatide. In a CMR sub-study of this trial, those individuals randomized to tirzepatide had significant decrease in pericardial adipose tissue in correlation to their clinical benefit with this drug. And the question is then, well, how much of this is due to just of this syndrome of HFpEF is due to obesity in the setting of diabetes as compared to diabetes itself? Well, I hope I proved that insulin resistance is a really important player, but this is a nice study, an old study, but a really nice study that demonstrates that diabetes is really an independent player in the development of cardiomyocyte dysfunction and heart failure. These are patients who had right atrial cardiomyocytes biopsied and were measured for contractile force and oxidation consumption. What investigators found was that regardless of obesity, those individuals who were diabetic had reduced myocardial contractility and reduced oxygen consumption, suggesting that, again, impaired mitochondrial metabolism and function is playing a big role in the setting of diabetic heart failure, specifically HFpEF. Impaired autophagy may play a particularly strong role in the development of heart failure among those with type 2 diabetes. Again, hyperinsulinemia is a bad player here in which increased insulin decreases autophagy. Autophagy is a cellular housekeeping process in which the cell is able to recycle its old byproducts and essentially clean up the cell. In the absence of this process, there's increased oxidative stress at the level of the cardiomyocyte and worsening cardiomyopathy. The concept of impaired autophagy in driving heart failure has been studied essentially through our trials of SGLT2 inhibition in heart failure in the Emperor-Reduced and Emperor-Preserved programs. Emperor-Reduced and Emperor-Preserved were heart failure trials of EMPA as compared to placebo. A subset of both of these trials had plasma proteomics at 3 time points. So individuals randomized to EMPA or placebo had over 1,200 proteins measured in the serum at baseline, 12 weeks, and 52 weeks, in which investigators were able to isolate the effects of EMPA as compared to placebo and saw which proteins differentially changed. And what was identified was several proteins related to improved or increased autophagy increased among those individuals who were randomized to EMPA, specifically IGF-BP1. Interestingly, there was no heterogeneity in the effect of EMPA on changes in these proteins, regardless of whether they were a reduced ejection fraction or preserved ejection fraction subtype, suggesting that impaired autophagy may drive or may be an important player in both types of heart failure. What about microvascular disease? We often consider HFpEF a disease of the microvasculature or coronary microvasculature. This is a nice study of look-ahead of type 2 diabetics, over 4,000 individuals. Those individuals who had microvascular disease at baseline, as defined by nephropathy, neuropathy, or retinopathy, had a very, very high risk of the development of heart failure. And if you look at the hazard ratios, 2.54 for any type of microvascular disease, 2.22 for nephropathy, these look eerily similar to the hazard ratios for diabetes alone. So the question is the route towards heart failure, and specifically HFpEF among those with diabetes, is diabetic kidney disease really the mediator here? And certainly is potentially for some individuals, but definitely not all. This is an analysis of the Emperor-Preserved trial. And as you can see, there are almost 50% of patients with diabetes and HFpEF in this trial had either a GFR greater than 60 or UACR less than 30. And so there's several, almost half of our patients with diabetes and HFpEF who do not have significant diabetic kidney disease but have already manifested with heart failure with preserved ejection fraction. The future, what does the future hold? I think that there are some important mechanisms that are as yet defined that we could potentially elucidate on how patients with diabetes ultimately develop HFpEF as compared to HFrEF. This was an interesting study of the TopCat trial in which investigators evaluated plasma proteomic differences between those individuals with diabetes compared to those without. And several proteins involved in inflammation tended to be higher in those with diabetes. So there's still more to this story that I think remains to be elucidated. In summary, diabetes is strongly associated with the development of heart failure. Disentangling the differential mechanisms of diabetes as compared to obesity and how they drive HFpEF is challenging, but likely lies in insulin resistance. And while diabetes confers risks of all types of heart failure, there are some mechanisms driving HFpEF that are likely distinct. That is insulin resistance, altered mitochondrial substrate metabolism towards fatty acid oxidation and away from glucose oxidation, and finally epicardial adipose tissue expansion and inflammation. Shared mechanisms include impaired autophagy, and we do need further investigations to really understand the mechanisms that specifically drive HFpEF and diabetes. Thank you very much.
Thank you. Our next speaker is Dr. James Januzzi from Harvard Medical School. He will review the screening and prevention of heart failure, risk stratification tools, biomarkers, and imaging.
Good afternoon, everyone. It's great to see you all. I want to thank the meeting organizers for having me come in today and speak on this topic. This is a subject that is important to cardiologists, endocrinologists, nephrologists, primary care doctors, pretty much everyone. When I received the title of my talk, because that's how it works, they give you the title, I thought this was great, but I did want to make one slight change. So rather than calling it screening and prevention of heart failure, I want to alter it to early diagnosis, and I'll speak to that point as we unpack the data that I'm going to show you, and then I'll let my colleague, Dr. Hernandez, talk about treatment. My disclosures are here. So by and large, much of what I'm going to talk about today is embedded within a recent consensus document that the American Diabetes Association published. And I want to thank the association for taking on this really critically important topic. And as a cardiologist and as the writing committee member from the American College of Cardiology, I want to congratulate the association for its forward-looking consideration for how we must get all hands on deck to identify heart failure in our patients with diabetes. So, as a cardiologist is wont to do, I'm going to simplify things slightly. And you heard a wonderful talk about the molecular mechanisms. I'm going to talk more about the epidemiology and the strategies for identifying heart failure in our patients. And I'll remind you that we talk about heart failure in 4 stages, stages A, B, C, and D, where C and D are the symptomatic stages. That's where the New York Heart Association symptom class lives. However, stage A represents individuals who are at risk for heart failure. By definition, a person with diabetes has stage A heart failure. On the other hand, stage B heart failure, critically important population, are individuals that have structural heart disease or evidence of congestion despite the absence of symptoms. Now, we can identify stage B heart failure in a number of ways. It's not practical to image every single individual who has diabetes, hypertension, or other risk factors for heart failure, of course. But should a person have imaging, the presence of abnormalities on imaging would identify them as having stage B heart failure. However, a more widely available option is the use of biomarker testing to identify a signal of cardiac stress, which in the appropriate circumstance may identify the presence of structural heart disease. But as I'll show you later, even in the absence of structural heart disease by imaging, an elevated natriuretic peptide value is associated with a substantial risk for the onset of overt heart failure. These are data that we generated from the Framingham Heart Study showing that persons with stage B heart failure identified either with imaging or biomarkers are at a 3 times higher risk for onset of symptomatic heart failure than persons who do not have this stigmata. And there was no heterogeneity by echo or biomarker. And we've seen similar results from other cohorts, as I'll show you. Furthermore, the presence of stage B heart failure alone was associated with a nearly 20% mortality risk by 3 years from the time of assessment. So really think about that, from no symptoms to mortality in 1 in 5 individuals. So this has led many to ask the question, how can we identify the risk of heart failure onset among people with diabetes? And admittedly, it is challenging. Certainly, clinical variables add substantially to the ability to predict risk. I am a clinician as well as a clinical trialist. I would never downplay the importance of clinical assessment in order to predict the onset of risk. However, clinical assessment alone is insufficient. And that's where combining different pieces of information to identify risk in order to ultimately, because as one question gets asked, well, just because you know they're at risk, what are you going to do about it? The good news is we have a lot of arrows in our quiver now to reduce the risk of heart failure onset among at-risk individuals. The use of risk scores, biomarkers, and imaging may all inform the risk in these patients and help us to make decisions. So again, I am a clinician and I will start with clinical evaluation. There are great advantages to clinical evaluation, whether you use them assembled in a risk score or just using your clinical intuition. Many clinicians are good enough without organizing into a risk score the variables that will help them to predict the risk for heart failure in their person with diabetes. There are several risk scores that have been examined for their ability to predict heart failure onset specifically in diabetes. They have advantages. They're simple, they're easy to understand, they facilitate treatment decisions, they can be integrated into an electronic health record, and that's all wonderful. Unfortunately, however, there's issues with calibration with many of these scores. In other words, in one group they may tell you one thing, but in another group they may tell you something else. There's less certain application in our patients who have type 1 diabetes, although I think, quite frankly, that's probably a concern we can put aside. And then lastly, more widespread use is needed. But that said, there's great advantage to some of the scores. I'm going to focus on the Watch DM score, which I personally feel is probably the best of the lot. This score incorporates a fairly good number of variables. It's not simple to remember, but they're all available at the bedside during our clinical evaluation of our patients. And there are simplified versions, including one that does without ECG parameters, importantly for those of you that do not do EKGs on your patients. One of the advantages to Watch DM is that it's been validated in a number of different cohorts. The Look Ahead, TCOS, and from an EHR experience from UT Southwestern, showing that individuals with the highest Watch DM scores have a some 5 times higher risk for heart failure onset over a relatively short period of follow-up. Again, remember, these are people who do not have symptoms. So a 5-year follow-up period is, essentially a snap in time for these people as opposed to someone with symptomatic heart failure. When, Dr. Hernandez and I do clinical trials in heart failure, a 5-year follow-up would be associated with a considerably higher risk for events. And yet, the risk of heart failure onset by 5 years in the highest quintile rivals that of people with symptomatic heart failure and reduced ejection fraction. So the ability to discriminate risk seems pretty good. So where do biomarkers fit in? And this gets to the point that there are patients who have relatively low clinical risk or who have relatively normal imaging and yet who have elevated biomarkers. And the concept here is the ability to detect the earliest signal of molecular abnormalities. You've heard that in the prior lecture, even before structural changes or clinical symptoms may appear. So what do biomarkers bring to the table? These are data from the Canvas study, of which only 14% of people at baseline had symptomatic heart failure. And yet, in Canvas, nearly 40% of people had an NT-proBNP at or above 125 nanograms per liter. Importantly, you can't really distinguish those who actually had prior heart failure from those who did not when you drop a cutoff at that 125 nanogram cutoff. So what does it mean if natriuretic peptides are elevated in diabetes? I looked it up today on PubMed. There are literally thousands of manuscripts addressing this topic now, so this is not novel information. But in adjusted models, an elevated NT-proBNP, for example, in Canvas, was associated with a 540% increase in the risk for heart failure onset during follow-up, regardless of baseline heart failure established. Furthermore, you don't need me to guide you to every one of the other endpoints in Canvas that were higher among individuals with elevated natriuretic peptides, notably including worsening of kidney function and progression of proteinuria. What about proteinuria? Of course, urinary albumin-creatinine ratio is the next biomarker that I think many of us are going to be measuring given the recognition of the benefits of the various therapies we now have available that not only reduce heart failure risk, but also kidney risk. So NT-proBNP and albuminuria, this slide says it's superior. Yes, it is superior, but I'm holistic. It's additive to urinary albumin-creatinine ratio for predicting the onset of cardiovascular events. So if you have someone with diabetes who has an elevated and not very elevated NT-proBNP above 125 and a UACR greater than 30, this individual has a substantially higher risk for heart failure onset than those who have either elevated or both low. The data are very clear that serial measurements are able to identify people who are changing lanes from low risk to high risk and from high risk to low risk. So secular trends in natriuretic peptide testing are powerfully useful for monitoring patients over time for identifying changes in risk strata. A major question, of course, is what do we do with biomarker testing? Is it cost effective if we measure a natriuretic peptide and then change how we manage our patients? We have data that are presented and soon to be published showing that in a decision model analysis, the use of natriuretic peptide testing did result actually in a modest increase in costs. But this increase in costs was due to increased prescriptions of guideline-directed medical therapy, the very treatments these patients should be getting, along with increased lifespan. And it was actually cost-effective with a quality of around 3.7 and an ICER of $44,000. So moderate to high cost-effectiveness by usual studies. So then the question is, do we need biomarkers if we use clinical risk scoring? And the answer is, it's additive information. So I won't dwell on this slide other than to say, WatchDM works well, but if you combine biomarker testing with clinical intuition or clinical risk scores, your ability to increase your discrimination for events is increased substantially. And the same thing goes for imaging. I hinted at this earlier, but it's not practical to image everyone. We know this. But if you have imaging information, as was shown in the ARIC study, and you have both stage B heart failure by echo as well as stage B heart failure by biomarkers, these are people I refer to as stage B+. They're teetering on the brink of symptomatic heart failure with the highest risk for incident heart failure, whether they have reduced or preserved onset or mortality. So this combination holistically of clinical information, biomarker testing, and when applicable, imaging would be the most logical and practical approach. So how do we do this? So this was a really neat paper published in Circulation that looked at a two-step strategy, which is to start with one test, and if normal, then go to another to make sure that there wasn't a miss on a sensitivity level. If the first step was abnormal, you're done. You don't need to, go from one thing to the next before you inform risk. In this analysis, WatchDM followed by NT-proBNP, NT-proBNP followed by troponin, or NT-proBNP followed by echo were compared. And what is shown here is that they were all pretty good for predicting risk, with a number needed to screen that was largely similar. Where they differed, not surprisingly, is if you start with clinical and then pivot to biomarkers, that is the most cost-effective approach, right? If you've got someone who's low risk, stated another way, if you've got a 50-year-old with 1 year of type 2 diabetes with well-controlled diabetes, no proteinuria, no hypertension, no LVH, the likelihood that a hit on screening with anything else is very low. On the other hand, if you have a 50-year-old with 10 years of poorly controlled diabetes, hypertension, CKD, et cetera, if the clinical risk it falls in the low to intermediate range, take the next step to biomarker testing. Because we actually know that by identifying risk, these are 2 RCTs based on natriuretic peptide selected intensified treatment, that when a person has an elevated natriuretic peptide and they are managed differently, their risk may be reduced. That is why this approach of selective natriuretic peptide early diagnosis for risk prediction is embedded in the cardiology literature and in our guidelines, as well as in the ADA standards, as well as in the consensus document that I mentioned earlier, where natriuretic peptides are recommended, and high sensitivity troponin if you prefer, on a yearly basis among individuals at risk. Now, of course, this is a potentially controversial topic. Do we have a suitable screening test? I would say arguably, absolutely yes. The combination of clinical variables, natriuretic peptides, and imaging provide ideal sensitivity and negative predictive value. Do we have an agreed upon policy in whom to treat? I would say this is not about biomarkers for everyone. A rational deployment in individuals at higher likelihood for benefit from this approach, I think, is something we should all agree upon. Are there harms from over-treatment? I would argue vigorously the harms of undertreatment are far greater given the humongous gaps in treatment. Do we have a treatment strategy? I'll let Dr. Hernandez answer this, but I'll end with this point, which is that when I talk to clinicians who say, oh no, but I use SGLT2 inhibitors in everyone with diabetes and proteinuria and heart failure risk. In 2021, there was a paper published saying that around 12% of such patients received an SGLT2 inhibitor. But all right, that's 2021. What about in 2024, 12%? So there are massive treatment gaps that we need to close. And so this approach of a clinical followed by biomarker and imaging strategy would be expected to allow us to apply therapies to our highest risk patients and reduce their risk. And I will stop there. Thank you very much.
Our final speaker is Adrian Hernandez from Duke University, and he'll review new developments in heart failure therapy for the endocrinologist.
All right. Thanks for having me here. And also, I want to thank everyone for bringing the North Carolina heat to Chicago. I was really worried that I was going to miss the hot weather this week in Durham. So I'll talk a little bit about some of the new developments in heart failure therapy and emphasize some things that we see in the cardiovascular field that hopefully will be relevant to you all. Here are my disclosures. So first, I want to start off with just underscoring what we have as a so-called tidal wave of cardiovascular problems coming up. And so everyone in this room has a role to really change this. Last year, there were a couple of publications that came out from the American Heart Association forecasting the burden of cardiovascular disease and stroke in the U.S. Through 2050, and was essentially taking a look at different risk factors and what the trajectories were, and then what the downstream implications would be if those risk factors continue on in the directions they've been going. And the summary is, if we don't bend the curve, we really have a gloomy forecast for 2050. And there's an interesting story behind this in that there's some of the risk factors you'd imagine are continuing to grow, such as diabetes and obesity, but others are actually forecasted to improve, such as high cholesterol. And so that actually may be illustrative of what actually happens if you look in the past when the cardiovascular communities and the endocrinology communities come together to really tackle a major risk factor, that you can see that actually can make a difference over time. And so likewise, I hope we can do the same for diabetes and obesity, because the forecast of those growing is really poor. Diabetes and obesity is going to continue to climb. And even though a lot of the efforts in this meeting is actually sharing new data that's emerging, there's essentially not enough that's being done for these two major problems to prevent cardiovascular outcomes and also prevent the onset, for example, of important areas such as heart failure. So all these conditions are slated to grow over the next several decades. And it will be costly. And so the estimated costs right now are over $600 billion, and it's forecasted to go 3 times higher than that in 2050. And you can see here the different areas that are actually going to contribute: coronary disease, stroke, AFib, heart failure, and other cardiovascular disease. And when you look at the risk factors actually driving this, it is driven by the diabetes explosion. And so, relatively speaking, hypercholesterolemia has a less contributing factor here to the projections than diabetes and hypertension. So this is a huge area for us to tackle. Now, one of the major innovations recently in the heart failure space is actually see it and do something about it. And I want to give you 2 case scenarios and see what you think in terms of how approaches have been, could be modified. One's not in the cardiovascular space, but Just imagine, this is actually a routine care scenario now, 60-year-old woman who comes in with an abnormal mammogram. Now, most systems have a pretty robust method of going from an abnormal mammogram to immediately getting to a biopsy, a diagnosis, either benign or malignant, and then having a plan. And that's actually pretty routine, in part because patients demanded it. Part is actually the anxiety that comes up when someone has uncertainty and the potential for cancer. And so nowadays, we see this routinely in systems of care where someone is going from similar idea of what Jim was saying, potential risk to acting on it if it's indeed really a risk. Now, if you consider similar scenario, and a 60-year-old woman comes in with an abnormal echo after being referred for symptoms of dyspnea on exertion, she gets started on a diuretic, referred to cardiology, shows up, unfortunately, in the ER before her appointment, and then hospitalized, and then initiated other heart failure therapies. And unfortunately, this is too common a scenario that we have the tools potentially to screen, diagnose someone, and act on it, but we haven't been actually utilizing that very effectively. And so I think one of the themes that's coming up is that how can we be much more proactive in terms of identifying patients with heart failure and treating them. And when you compare these two scenarios, and ignoring I don't have any biopsy results, but in general, the case on the right has a much worse prognosis than the case on the left. So that's why there's been a huge emphasis on moving rapidly and considering someone who gets diagnosed with heart failure actually as an emergency. We should be able to treat that really quickly to lower their risk. And with guidelines that have been developed over the last few and published 3 years ago, really emphasizes 4 pillars of medical therapy. I'm going to highlight HFrEF and then talk a little bit about HFpEF later. But the 4 pillars of therapy are considered to be rapidly implemented. So RNase, ARB, beta blocker, MRAs, and SGLT2 inhibitor. And these therapies should be really started in a way that is rapid and their dosing escalated to get to the optimum guideline-directed medical therapy. And now people have programs that actually illustrate how to do this in a way that would be similar to if someone was managing a patient with cancer or a significant problem with an infection. And so on each day or each week, making sure that there's a stepwise plan so that within a couple of months, as opposed to a couple of years, everyone is on the 4 pillars of heart failure care without delay, and also making sure there's no risk in terms of having events in the interim. And this is all underscored by data that has been demonstrated across different clinical trials, that the benefits appear within days to weeks following initiation of medical therapy. And so in each category, you can see separation of the curves in terms of improving their outcomes, again, underscoring that there's no reason why to delay, and that just simply exposes excess clinical risk and what I'll call forgetfulness, that people get lost in the system, people somehow don't necessarily know why they weren't on something, and then there's a missed opportunity. Now, there's also some other questions that commonly come up, and so one is just timing or ejection fraction. Does that matter for SGLT2 inhibitors? And there's data that's been emerging over the last couple of years highlighting that rapid initiation is beneficial, and ejection fraction doesn't matter in this scenario. This is just one example of a meta-analysis of 2 trials coming together, DAPA-HF and DELIVER, showing that actually the early outcomes are significant after someone's been hospitalized recently. And then also importantly, the effects of intervention early on matter, and also matter regardless of ejection fraction. And so again, underscoring that someone who has been hospitalized recently is very high risk, and treatment early is also very beneficial, regardless of the EF. And this is also translating to guideline updates, again, giving Class 1B in the European guidelines for heart failure. Again, emphasizing an intensive strategy for initiation and rapid up-titration of evidence-based treatment before discharge and during frequent and careful follow-up in such a way that the first 6 weeks can be really emphasized after someone has been hospitalized in terms of getting their life-saving therapies. And then further along, the guidelines continue to be updated to emphasize the SGLT2 inhibitor classes of drugs being relevant for across EF, so giving class 1 indications for patients with HFpEF, as well as so-called mid-range ejection fraction. Now, let's address the big question often in the room, which is around obesity. So this is now really has the world's attention, especially through meetings like this. And often we see this in everyday clinical practice, but still have problems in terms of how to implement therapies, especially those who have heart failure. So one of the questions comes up is, do they have heart failure, or is it because of their weight, or is it both? And the answer is probably yes, both. And it is indeed complicated. And so, but I'll have to say, and I picked this out recently because of such a great author group here highlighting this in a recent publication for the ACC, a scientific statement on the management of obesity in adults with heart failure. And so even us cardiologists now have a simplified approach thanks to this statement, and underscoring the need to do this with a multidisciplinary way, as well as not just thinking about this as anti-obesity medications, but also the combination of behavioral change, diet, and exercise with anti-obesity medications and other options if needed. And this does take a team approach. And while there's not enough endocrinologists to serve all the people who have diabetes, obesity, heart failure, et cetera, having programs locally where we can tap in that expertise is really important. And especially as we think about, how to get people on these medications and titrated to the appropriate dose, and ensure that they stay on these medications long term, since maintenance will be an important factor. And now we're also learning every week, it seems like, that these anti-obesity medications are more than just weight loss medications. I'm just highlighting an article that's in a cardiovascular journal, JACC, highlighting that, again, you can see a drop in NT-proBNP levels with anti-obesity medicine such as SEMA, but more importantly, you can also see effects on heart failure symptoms that are more pronounced at higher NT-proBNP levels. So it's not just the weight loss that's having an effect, there's something else. And so there's really this idea of obesity plus here. So as we go forward, we need to continue to work together to address the benefits and risk of these different therapies. And so there are a couple ideas that have emerged in at least the cardiovascular space, is that sometimes these therapies may actually enable tolerance for each other, that we may not necessarily think about it as complementary or synergistic, but that may be the case, that you can see the combination of therapies of SGLT2 inhibitors or ARNIs and MRAs can be helpful in terms of being able to tolerate some of the potential effects or side effects that can happen, such as hyperkalemia. And this is underscored with data showing that initiating an SGLT2 inhibitor or switching to an ARNI reduces MRA discontinuation. Again, an important pillar in that if we can have combination therapy, that is probably the biggest bet for managing heart failure and improving their health outcomes. And one of the areas that we really need a combination of team efforts, bringing all the expertise between cardiology and endocrinology together, is that often patients will comment on different side effects. And what they may read through Google or hear about are some of the side effects for which they trust people in the endocrinology community to actually help understand what's that side effect relative to the benefit. And so often we have these consultations that come up as that, hey, why should I be on this therapy? Or I'm having such a problem, and what's the relative benefit? Such as if someone's having GI effects for a GLP-1, or in patients who have infections and whether they should continue on SGLT2 inhibitor, or some other interesting areas that are going to continue to grow in terms of, we'll see this, questions about changes in lean body mass, frailty, sarcopenia, and how those should be managed if we're trying to manage their heart failure while managing any side effects or preventing that. So, and final thoughts here is that burden of diabetes and obesity is growing, so pun intended. Impact is enormous, people and cost, and the advancement that we've seen in heart failure is really thinking about these metabolic medications with and without diabetes, that they're actually something much more than that. And both communities will need to continue to come together to manage the benefits and risk to improve outcomes, similar to what happened decades ago for hypercholesterolemia. So thanks, and look forward to the discussion.
So as we wait for people to come to the mics, I do have a question. I apologize in advance for it being a little bit long. But Jim, you had touched on the economics of performing wide-scale screening of asymptomatic individuals with diabetes with N-terminal proBNP testing. As you know, there have been some concerns that that might not be an economical approach, in part because of an expected increased number of referrals of patients to cardiologists. For the sake of this audience, if we were to implement screening of that type and we identify asymptomatic individuals with elevated biomarker testing, what happens next? What is appropriate within the context of an endocrinology or diabetology or primary care practice as the next steps?
Yeah, great question, and thanks for framing it up that way, because you will identify people. And very importantly, back 25 years ago when we first started measuring NT-proBNP experimentally, and people had elevated values, and they didn't have obvious heart disease, we used to call that a false positive. But we now recognize, after many years and many thousands of studies, that these people have a higher risk. The question then comes down to, why do they have a higher risk? And having, as we wrote in the consensus document, and I think it's rational to consider, a cardiovascular evaluation, an echocardiogram, and a reassessment of management from top to bottom, not just drug therapy, but nutritional therapy, weight loss management, optimization of glycemic management, removal of DPP-4 inhibitors, consideration of avoidance of other medications that might increase risk for heart failure, and focusing on closing the massive gaps in cardioprotective care that our patients have is really critically important. And I would emphasize, by the way, swap out NT-proBNP and swap in UACR. It's the same risk, it's the same management. And so very importantly, as we cardiologists are going to start measuring UACR, I think it's important for endocrinologists to be thinking about NT-proBNP.
Maybe that could be a trade-off. So if we can get cardiologists to do that for the BNP by others.
Right, exactly. I mean, I'm sure I'll be sitting up here at the ACC meeting telling cardiologists to measure UACR and, having the same sort of questions.
Yeah, great. Sir, I think you were first.
Yeah, thank you. Hassan from Alexandria, Egypt. In the last CVCT meeting in Washington in December, the meeting run by Professor Zanat from Paris, there was a hot debate and discussion whether GLP-1 receptor agonists are contraindicated in stage B or C or D. I mean, maybe C or D. What's your opinion about that point?
Well, I missed that debate, but I've actually been reviewing some papers around that issue. And so certainly the strength of evidence has been around HFpEF, and the question has been whether it extends in other areas in terms of HFrEF and the severity of heart failure. Now, I'll just say, like, the strength of evidence continues to emerge that it looks like it can be very powerful across all, but we certainly would love to see greater evidence to fill in those gaps. But Jim?
Yeah, I think, the studies are we need outcome studies in HFpEF, but studies in reduced ejection fraction heart failure are really needed to help allay some of the concerns that came about during the liraglutide era in studies of reduced EF where the drug seemed to increase risk. Importantly, in the liraglutide experience, these were more decompensated, higher risk patients. And yet, in SELECT, for example, people with a history of heart failure and low EF actually had similar benefits as people with preserved EF or no heart failure. So I think in the end, it comes down to the patient. In other words, if you've got someone who's decompensated on the brink of hospitalization, starting them on a drug that induces nausea, diarrhea, and other things that might destabilize them further might not be the most logical thing.
And just on that last one, so the kind of main study, and this was at the beginning of that, was a study called FIGHT, so which we wind up being really surprised at because it seemed like a no-brainer that it would work in that setting. But these are really sick, acute, decompensated heart failure, and so we probably didn't really imagine all the things that are happening in that vulnerable period within the first 30 days of a hospitalization.
Next.
Hi, Jay Lusk from UNC and Duke. I'm curious to hear y'all's perspective on how we can implement some of the approaches you've talked about in primary care settings. In particular, thinking about the question of decreasing our lag time from identification of high-risk folks with heart failure or even initial diagnosis of heart failure in an ambulatory setting, and then trying to begin treatment and begin disease monitoring in the primary care setting as we're awaiting referral to specialty care, particularly in cardiology. And to some extent, if you could talk about how we can advocate for systems and culture change to effectively implement some of those strategies in our own institutions.
Yeah, well, so I'm hoping that, we can have easier tools for primary care and family practice to use. So it's much easier in terms of integrating a practice. And so with all the different things that people in primary care have to handle, having kind of one segment being semi-automated in terms of like, this is a screening approach for this high risk, here's a button to easily push, and then what's next may be effective. But I think those will take systems of care approaches here. So look forward to you solving this problem as I know you're working on it.
Yeah, it seems like everyone in here is from Duke. Just one example at Mass General. So I'm a general cardiologist. I'm not a heart failure specialist. But I saw that although our heart failure service did an outstanding job of getting GDMT in place for patients they see about 5% of the patients with heart failure at Mass General. So in our general cardiology practice, I established, actually with Aphrodita Spahulari, who's now at Duke, a GDMT clinic run by, we have nurse practitioners, physician's assistants, and pharmacists. And those patients are referred from general cardiology, EP, the fellows clinic, in other words, anyone other than the heart failure section. We published our first experience 6 months ago. We have our second group of patients, 90 to 95% on 4 drugs for reduced EF. So it can be done and can be done within a 6 to 8 week period, and then the patients are released back to their referring doc. And to me, that is a practical approach that it doesn't need to live in cardiology. It could be in primary care.
Yeah, and we have that same medication adherence titration clinic primarily led by pharmacists at Northwestern as well for general cardiologists. Like Jim said, send them back and we see they're on these maximally tolerated 4 drugs. And it's something that I think could easily be implemented at the primary care setting, albeit at a larger scale.
Thank you.
Dr. Phillips?
Could you help us a bit to understand the contributions of diabetes versus hypertension? Because I personally think that inadequate treatment of hypertension is probably a more widespread and bigger problem than inadequate management of diabetes, notwithstanding the lack of a fall or lack of improvement in A1C over time. The second question is, we'd like help in when to use and how to use diuretics.
Do you want to answer the first part?
No. I think
Hypertension?
Sure.
Hypertension versus diabetes. You got.
Yeah, I think it's a great question. Hypertension undoubtedly is a strong causal mediator towards the development of heart failure, potentially a bigger epidemiologic problem for sure. I think in my mind, it's a combination of why not tackle both of these very strong risk factors simultaneously, because we now have therapies in both hypertension, where we know from the SPRINT trial that aggressive lowering of blood pressure reduces risk of heart failure markedly, and from EMPA-REG that there are anti-diabetic agents that reduce risk of heart failure as well. And so it's, to me, not a matter of one or the other, but how can we manage both effectively to prevent heart failure? And I did miss the second part of your question.
I think it was about the role of diuretics.
Certainly, the role of diuretics, I think, plays a strong role in antihypertensive management, thiazide diuretics specifically, which have shown to prevent heart failure hospitalizations. In terms of loop diuretics, our hope is, I think, when we have a patient with heart failure, to prioritize these other 4 agents, especially in the reduced ejection fraction population, and oftentimes obviates the need for a loop diuretic. And if a diuretic is needed, potentially a thiazide may be more beneficial given its effect on blood pressure as compared to a loop.
One other comment, always good to see you, Dr. Phillips. You've always been able to ask the easy questions over the years. So one other comment, which is, and there's systems of care that have actually prioritized hypertension management in terms of having the biggest population impact relative to diabetes. And so that certainly underscores what you were saying in terms of hypertension management. The one issue about that is that right now, at least for getting people to stay on antihypertensive medications, is still really hard. And so at least we're starting to see some movement with anti-obesity medications as other reasons that people have a so-called biofeedback in terms of staying on those therapies. So we'll see how it turns out.
Sir, I think you'll be the final question.
Jose Cara, New York. As a pediatric endocrinologist, I worry about adolescents who are obese and have diabetes, obviously in part because they become adults who are obese and have diabetes. Other than managing obesity and diabetes, which are in and of themselves obviously quite challenging, are there any specific guidelines or treatment recommendations for prevention and or treatment of cardiovascular disease in those individuals?
An incredibly, incredibly important question. That's almost like primordial prevention, right? And for our youngest patients, particularly those with type 1, unfortunately, we don't have data. I think it's reasonable to say that controlling the factors that were just discussed, if these individuals develop early onset hypertension, treatment of obesity, monitoring and management of DKD in these patients, critically important to reduce their risk for onset of heart failure. I saw some data that heart failure onset in younger patients with diabetes is around 15 years earlier than among individuals who develop type 2, say in their 30s, 40s, 50s. So it's reasonable to say that early diagnosis, notice I avoided the word screening, Early diagnosis should be applied at an earlier time. And this gives me a chance to just once more say, when we're making early diagnosis attempts with biomarkers, for example, it's not a one-size-fits-all. It's important to think about the patient you're testing and the timing of it. And someone that you described, for example, would certainly merit testing at an earlier time point than, say, a 40-year-old whose A1C is 6.1% or 6.4% on diet, right? And so individualizing care is going to be critically important.
Well, thank you. Oh, I'm sorry. Thank you to the audience for all of your questions, and let's give a final round of applause to our outstanding speakers.